Hello, I'm Adrianna Jensen, and I'll be discussing the incidence and characteristics of orbital hemorrhages in the United States from 2006 to 2018. Orbital hemorrhage can be a true emergency, rapidly leading to permanent vision loss if there is an orbital compartment syndrome. Thankfully, orbital hemorrhages occur in less than 4% of traumas and orbital fractures, typically in male patients via assault, motor vehicle accident, or fall. There's currently no national-level investigation of this condition, but considering massive U.S. healthcare spending and the drive for cost-conscious care, physicians must understand the costs of this condition and the demographic and clinical factors at play. As such, we utilized a nationally representative sample of U.S. ED visits, the Nationwide Emergency Department Sample, or NEDS, in a retrospective longitudinal study to examine orbital hemorrhages in the United States from 2006 to 2018. Data were extrapolated to the entire U.S. population. We examined both primary diagnoses, those primarily responsible for presentation to care, and secondary diagnoses of orbital hemorrhage. The incidence of all orbital hemorrhage diagnoses increased more than 4.3-fold, as can be seen on the left in blue, while primary hemorrhages alone increased about 2.9-fold, as seen in orange. The most precipitous increase was from 2015 to 2016. The elderly clearly dominated age-specific incidence, as seen in green. Young adults, and the elderly demonstrated a similar about 2.5-fold increase in age-specific incidence of primary orbital hemorrhage, as can be seen in this plot, whereas children experienced a striking 6-fold increase in incidence, as seen in blue in this plot. Primary orbital hemorrhage patients were on average 49.2 years old, and the largest proportion of patients were elderly. Most patients overall were male, but elderly patients were mostly female. Medicare was the most common primary payer, with most of the elderly covered in this way, though a notable fraction of young adults were self-pay. The most common overall mechanism of injury reported in primary orbital hemorrhage was fall, as can be seen in orange, followed by assault, as can be seen in gray here. All examined mechanisms increased in incidence over the study period. Notably, fall-related primary orbital hemorrhages increased over 34-fold, while assault-related hemorrhages increased 6-fold. The elderly made up most of the fall-related hemorrhages, as seen in blue, in the upper right, while young adults made up most of the assault-related hemorrhages, as can be seen in the lower left in gray. In contrast to significant increases in fall and assault-related diagnoses, overall assault incidence decreased over the study period, and fall incidence increased by only 15% or less during this period. The most common associated ocular injury among any group was contusion, though coding of associated ocular injury was generally uncommon. Otherwise, lateral canthotomy was coded in only 3% of primary orbital hemorrhage cases and 3.2% of total orbital hemorrhage cases. The total estimated emergency department cost for primary orbital hemorrhages over the study period was $22.7 million, with annual inflation-adjusted costs increasing by more than 13-fold over the study period, as can be seen on the left. The greatest annual increase was from 2015 to 2016. Mean inflation-adjusted cost per visit increased less precipitously, only about 4-fold, as can be seen on the right. Only 9% of primary orbital hemorrhage patients were admitted, but total inpatient charge from 2006 to 2018 was $17 million. There was a trend toward increased odds of admission among the elderly and decreased odds for female and self-pay patients. Both fall and object-related injuries incurred decreased odds of admission, while certain concurrent injuries like open globe or maxillary fracture were associated with increased odds. Incidence and cost of orbital hemorrhage diagnoses in the ED increased substantially from 2006 to 2018, and especially from 2015 to 16. These sharp increases coincided with the switch from ICD-9 to ICD-10 coding in October 2015. The greater number and detail of ICD-10 codes is likely responsible for the coding and cost increase. Consistent with past outpatient analysis, mean cost per visit did not spike from 2015 to 16, rather increasing fairly steadily from 2006 to 2018 and exceeding the 68% increase in national health expenditures over that same time, perhaps secondary to trauma imaging costs. Demographics and mechanisms of injury were consistent with those reported in smaller-scale analyses. In particular, a high rate of orbital trauma from falls has been reported among the elderly, especially women, and we noted a similar trend. We also observed a precipitous increase in fall and assault-related orbital hemorrhages. The increase in fall-related orbital hemorrhages was 17 times greater than the increase in fall-related orbital fractures noted in a recent NEDS analysis. This increase is spearheaded by the elderly, though only partially accounted for by the growth of the elderly population. As such, fall-related injury represents an increasing threat to the elderly. And fall prevention is an area in particular need of strategies to mitigate injury and cost. However, the elderly made up a variable but similar fraction of the age-specific incidence of falls throughout the study period, indicating that falls are an important source of increasing morbidity for all age groups, especially as fall-related hemorrhage far outpaced the increase in falls in general. Assault as an etiology of orbital hemorrhage also outpaced the trend in assault incidence in the U.S. as a whole and in the NEDs, suggesting that at least a subset of assaults are becoming more violent, and bringing further attention to the importance of public health and policy measures to decrease violent crime. Finally, there was a trend toward decreased likelihood of admission among self-pay patients, suggesting possible decreased level of care based on insurance status. However, it's challenging to make any definitive conclusions here due to lack of statistical significance and the fact that the elderly are most likely to be covered by insurance and most likely to be admitted. Regardless, this trend deserves further analysis. Fall and object-related orbital hemorrhages may have artifactually decreased odds of admission, as these hemorrhages, when part of a condition severe enough to be admitted, could be eclipsed by another injury such as an intracranial bleed when choosing the primary diagnosis. Moreover, lateral canthotomy was coded in an overall low but variable rate among both primary and secondary orbital hemorrhage diagnoses. At around 3% of these patients, this was consistent with prior studies. In conclusion, we examined the incidence, characteristics, and costs of orbital hemorrhages in U.S. EDs. Strengths of our study include use of a nationally representative sample over more than a decade and inclusion of both primary and secondary diagnoses. Our study is limited by the potential for coding errors or omissions. The rising incidence of orbital hemorrhages emphasizes the continued importance of recognition and treatment of this entity. The large increase in fall and assault-related hemorrhages, along with exponentially rising costs, further informs public health efforts for the mitigation of facial trauma. Thank you for your attention.